at the piriformis, I will have Joe keep the leg straight. Joe, lift that leg off of the table, and you can really feel the flexion. So I know I'm in the right spot. Then I'm going to have him make a circle with that leg extended like that. And what that does is, it not only warms, it helps break down that the piriformis, or the trigger that we're working on. It could be nearer to the sacrum, it could be nearer to the iliac crest. But they will then be actively working to help you break down that trigger point. It happens much faster and is much less of an effort on your part, because moving an entire leg is exhausting. Okay? And just lay that back down, relax. Thank you. And that would be INIT with movement, something that you can do with an active client, someone who doesn't have a history of chronic low back pain. Okay, so that's used advisedly. That is not something that you would use with, again, someone who has a history of disc problems, who's had surgery, those kinds of things. You're going to have to supply the muscle for that. But in many cases, it will go much faster, and the client will actually be involved, and many times an athlete, for instance, will be assertive and aggressive and be very happy to be part of this whole treatment process. Same thing for the gluteus medius and minimus. And Joe, if you would, lift that leg again and make a circle. And because that circle is covering all the points of the compass, that it also will flex for the medius and minimus. If I want to accentuate that, then I would say, Joe, bring your leg straight out to the side and hold it there. I might even add a little bit of pressure and work back in that way. Okay? So, whether you're working with the superficial gluteal muscles or with the deep hip rotators, lateral rotators, if you have a client who's willing and in good health, then that INIT with movement can save you a lot of effort and time. The largest of the lateral rotators is the piriformis, and we have read and looked at that in the ACB. It inserts at the trochanter, and it originates at sacrum, just as the gluteus maximus and the other lateral rotators do. But being the largest one, also the fact that the sciatic nerve runs under the piriformis, and 15% of the people actually runs through the piriformis, then that is a prime area to work, especially if there's any kind of sciatica and sciatic pain. So we have seen one way to work with that release, which is the more general. We've done this. If the piriformis is painful, then you can do your just kind of a general position of comfort. But to actually be more specific to the lateral rotators, you would want to move the leg across. And what this does is, this then passively will relax those muscles, and that would be your position of comfort for the piriformis. And then you would bring it out just a little. You don't want to get too aggressive there. And that would be, and then you would have them press back in. Their ankle would come in to activate that, and that would reset the proprioception. Okay? Now, a nice, simple way to get that piriformis to release is to work with the rotation of the hip by using the flexed knee. Okay, but all the way across is your position of comfort. Should it be real painful, should you have a person who this was too painful for them, then you would move all the way into the position of comfort. And of course, you'd have to be careful of any knee issues, but that would be on your referral information. And then you would bring that gently to the outside, and with that 20% effort, they would reset the proprioception for the piriformis. Okay? And of course, we know the third way to do that is simply to flex that entire area. And as they flex that area, it will flex the piriformis along with the other gluteal muscles, and relax. And then press the knee into the table, which flexes the piriformis or the hip flexors, which are the antagonist muscles to the glutes and to the lateral rotators, and relax. Okay, so that's the isolations for the piriformis and the lateral hip rotators. The next group of muscles will be the hamstrings and the posterior leg, and these originate at the ischial tuberosity and then come down to the knee and below the knee and insert into both the tibia and the fibula. And again, the ACB will give you those attachment points. But this muscle is a large muscle, and it's always good to warm up these muscles, especially if you're working on a large muscular person or an athlete, and you'll want to do some stripping, which is nicely done with larger muscles with the elbow. And what you'll want to do then is assess and watch your client's reaction for any jump sign. If you are finding some tender points, and then you can progressively add a little more focus with the tip of the elbow. But it's very common to find tender points at the origin or throughout the body of the hamstring. And of course, the hamstring activates this simple hinge joint at the knee. Because the joint is simple, the musculature is also fairly simple and straightforward. When you work with the hip socket, the ball and socket there, then because you have a rotation component, you have a more complicated task when you are trying to figure out what the muscle isolation would be. Again, the muscles still pull in straight lines, but as we know, when there's a joint involved and a lot of different muscles, then that can get a little more complicated. Here we have a simple structure, a hinge joint, and so we're going to have an easier time with these isolations. Okay? So, if we found a trigger point, and it's not uncommon to find them in the first 3 inches above the knee, then the position of comfort, quite straightforward. This is moving into that position of comfort. We are slackening the muscle, and you don't want to put them into a cramp. Hamstrings are easily seized up that way, so you'll come just as far as you need to get them out of pain, and then the extended position is flat to the table, and then you are going to ask for a 20% effort on that flexion, and you can see that just jump right up, and that resets the proprioception. Okay, so quite simple on the posterior part of the leg and the hamstrings. Now, if there were involvement of the glutes, if there was a pain that went right up into the low back, we would simply have Joe come up a little bit to the side, bring the leg up kind of in that C position, but then we just straighten the leg. And then when we ask for that flexion, it would also involve the glutes. So you could simply and easily extend that isolation into the glutes and the hip muscles if that were where the pain were related and involved. Now, below the knee, we have you have the gastrocnemius. Deep to that is the soleus, the plantaris that is deeper yet. But in this case, we have, again, a fairly simple joint. But this also has a little bit of a rotational component. So when we find triggers here, this is a fairly straightforward position of comfort and extended position. But if we work to either side, then we'll just add a little more of a rotational component to take that into account. In fact, that rotational component is good to get the coordination involved in that entire group of muscles. Even if it were to be in the gastrocnemius and to be largely in that simple plane, the rotational effect will get the coordination with the other muscles involved too. So when we're working below the knee, again, the foot is our tool, so to speak. The position of comfort is in this slackened position. The extended position is going to be here. A 20% effort will reset the proprioception. And that will be the isolations for the posterior leg. If there were to be anything in the IT band, which again follows along that same line as the gluteus medius and minimus, then we would simply have them press laterally, and you can feel that flex anywhere from the greater trochanter right down and below the knee, because the IT band does go below the knee, and relax, and then we could have them flex then medially. And if we really wanted to stretch that out, we do the very same thing that we've been doing, which is to have this leg straight and bring it right across so we get a nice stretch along the length, the lateral edge of the leg. So there's a lot of moves that will be common to more than one isolation, and that allows us to work a little more effectively, a little more efficiently. And that will finish for the posterior legs. The isolations for the anterior lower leg will be very similar to the isolations for the posterior leg. The joint structure is the same, and so your rotational component is going to be the same. And the major muscle here in the anterior leg is going to be the anterior tibialis. Okay? And as you work that and do your stripping and your warm-up, of course we always do a good warm-up with our trigger point work, then your position of comfort, that slackened position, is here. And the extended position is here and a little bit inverted. Okay? Anterior tibialis actually comes across and inserts into the arch of the foot. But that rotational component is always a good backup isolation, and in this position then I would ask for a 20% effort to reset the proprioception for the anterior tibialis. Okay? And a good follow-up for that might be just some rotation that the client does, and I give them a little bit of resistance. I want you to keep rotating that foot, Joe, and I'm going to give you a little bit of resistance, and that is going to then coordinate groups of muscles that work and combine to produce that movement. And by rotating the foot, not only do we reset the proprioception for the anterior tibialis, but we actually reset proprioception for all of the muscles that combine and integrate with the anterior tibialis to produce that motion. This is another example of the INIT with movement. This is a good way to kind of accelerate the process, and the proprioception then is activated all through that range of motion. The next muscle group in the upper anterior leg is the quadricep group, and you have, it's interesting here, you have the three vasti are deep, the medius, intermedius, and lateralis. And then you have the rectus femoris, which has a different name because it's the only one of the four that extends up to the hip. It actually becomes a hip flexor and extends the lower leg, where the other three, the vasti group, only extend the leg. So when we do our muscle isolation, we're going to hit all four, but you need to understand that for the rectus femoris, you also would need to do actually a hip flexion for that isolation. So as we look at the quadriceps, then our, again, the joint being a simple hinge joint, we have a simple movement, and wherever we might find a trigger point, our position of comfort actually would be with the leg lowered, and the muscle then would be in a slackened position. And in order to work in the extended or flexed position, then we would bring the leg here. We would ask for a 20% effort to straighten the leg, and you can see the muscle flex here. That's the 20% effort that we would use to reset the proprioception. Now, moving from this position of comfort to reset the proprioception, then we'll go into this position and we will ask for a 20% effort, and you can see the muscles flex here, and that is what we want for the resetting of the proprioception. And just relax, Joe. We might even go a little bit further. We might take this in a 2-step process, even a 3-step process, because you want to be careful. The hamstrings can cramp, the calves can cramp, and so you want to do this gently. But continuing on, this will give you greater and greater lengthening of the muscle with that 20% effort to reset the proprioception. Now, continuing up the leg to the tensor fascia lata. Now, the fascia lata is that area of connective tissue that the IT band, and the fascia lata ties into that, and it raises the leg and lifts the leg and abducts the leg. So your position of comfort, and maybe you've noticed this, but the position of comfort is where the muscle would actively move, but you do it passively. Okay? So that can be confusing, but the position of comfort for any of these muscles is when you, for instance, in the bicep, when you would flex the bicep, if you did that passively, that's your position of comfort. And then you would bring it down and as far to the side as you can. That would be your lengthening, and then you would ask for a 20% effort in lifting the leg up and towards you. The isolation for the tensor fascia lata, this is a muscle that when we've moved above that simple hinge joint, we're back up into the ball and socket of the hip joint, so you do have some rotation here. But the tensor fascia lata ties into the IT band, and the IT band runs down the lateral side of the leg. The tensor fascia lata will lift the leg and abduct the leg, abduct the leg. Now, you may have noticed this, but the position of comfort is that passive position where the muscle would have actively contracted and moved the leg or the limb. Okay? So if Joe were to actively lift his leg up this way, that is the same position. When I do it passively, that is the position of comfort, because that is the slackened position when it's done passively. You may have noticed that the position of comfort done passively is the same position if Joe were to do this actively and lift that leg and contract the muscle. Okay, actively. Done passively, that is the position of comfort, because the muscle is in the slackened, shortened position, but it's passive. Okay, that can be a little confusing, but that would be the position of comfort. And then for the extended position, we would adduct the leg and lower it. We would ask for a 20% effort, and this is going to be an effort to lift and abduct the leg and relax. And that's the isolation for the tensor fascia lata. The abdomen is an area that you'll want to ask for permission to work. It can be an area that is uncomfortable depending on the client. Now, you have layer upon layer of muscle in the abdomen. The rectus abdominis lie vertically, and that is the six-pack that most of us don't have. There are the external obliques and the internal obliques, which have a little bit of a crisscross pattern, and then underlying all of those is the transverse abdominis. So you have those 4 layers of muscles. And when you do your warm-up then working clockwise in the direction of your digestion. You can warm up that way. If you are working with something in the obliques, then you can work specific to them, and something with the rectus abdominis, of course, would be right along the midline. But if we were doing something with the obliques, then we would have to passively bring their torso into that shortened position, and then in the extended position, we've asked them to give us a 20% effort to twist up towards us, and you can feel that flex as you do. Okay? And that would be for the obliques. For the rectus abdominis, depending on whether it's in the upper abs or the lower, in the upper abdominals, then you would actually have to assist your client and lift, and you can feel that softening as they are passively in that position. And then you would ask them to just give you a 20% effort and just kind of curl, and you can really feel that flex there. Okay? So that would be the resetting of the proprioception. Now, in the lower abdominals, then you're going to do kind of the knee lift sort of thing. We could bring both knees up, and we could then move into that passive shortened position. And then for the resetting, we would leave the knees flexed, and we'd ask them to just gently give us 20% effort, and you can feel the flexion there. Okay? Now, the lower insertion of the rectus abdominis and of some of the obliques is right near the hip and also at the pubic bone. So, for instance, many times in pregnancy, women will have trigger points laid down in this area. When you do work there, what I typically do is I will actually use their hand, I'll apply the pressure, and that is less invasive. But the same principle. Now, again, with someone who is assertive, aggressive, willing, I'll have them bring their knees up to a flexed position, and I'll try the INIT with movement if they don't have severe chronic pain. So just lift those knees up a little bit and extend it down a little bit. Slide the feet just a little bit towards, there you go, and bring it back up. Can you feel that working, Joe?
Oh yeah.
And you'd be surprised at that insertion into the pubic bone. Many trigger points are laid down. Okay, so those are the isolations for the abdominals. As you can see, you need to know the origin, the insertion, because like all muscles, they pull in straight lines, but the origin insertion, of course, has different orientation, whether it's the rectus abdominis or one of the obliques. And you must know that origin and insertion. So we'll be referring you to your ACB so that you can follow along as we do these isolations.
The iliopsoas actually consists of two different muscles that are located right next to each other. The iliacus fills the inner surface of the ilia and blends with the tendon of the psoas major and inserts at the lesser trochanter. The psoas muscle originates at the transverse processes and bodies of the lumbar vertebra and passes through to the front of the pelvis and inserts at the lesser trochanter, thereby blending with the iliacus tendon. This is the body's major hip flexor and the largest fight or flight muscle of the body. There's an excellent illustration of this in your anatomy coloring book. The psoas release can often be emotional and will be included with the video involving TMJ releases and sternocleidomastoid releases, because they are all highly affected by daily stress and emotional issues.
Now, for the iliacus, you're going to go right to the hip bone, the ilia, and you are going to simply kind of palpate right over the edge. And I start with this iliacus release before I go to the more medial psoas release, because the psoas obviously is more invasive, and you may have a complication if there are ovarian cysts, for instance. So we'll start with this iliacus release, and I start with the knee in the flex position because the iliacus helps, along with the psoas, to flex the hip. So in this position, we're already in that position of comfort. Because it's an emotional type of release, or it can be, this is a good way to start with this release. Joe, we're going to use our pain scale again of 1 to 10, 7 being pretty intense, but you can still breathe through it. You can still relax and breathe, okay? So you let me know. Okay. Now, this is the position of comfort, and we can do this passively by simply lowering the leg, or Joe can do it actively and lower the leg himself, depending on how he reacts to the pain and depending on his personality, how aggressive he wants to be. But you will continue to slowly palpate as the muscle releases, and you will find yourself penetrating further into the inside of that iliac pelvic bone. And you will actually be in an inch and a half when you are done, unless it is so painful that you have to take it in stages and you won't try and work all of that in one session. But then the next thing we would have Joe do is lift the leg if it were too, and the knee can stay bent. And if it were too painful, then I would passively raise that for him. And we would bring the knee up 2 or 3 times if need be. And we would finish with the leg in the straight position, which is going to be the flexed. And then we would ask for just a 20% effort to reset that proprioception. The companion muscle to the iliacus is the psoas, which begins at the lumbar vertebra and comes down at an oblique angle and attaches to the inside lesser trochanter of the femur. Again, refer to your ACB for that. So on that line, we will be a couple inches over from the navel, a couple inches down, and then we will slowly palpate, and we're going to watch our client's face closely. And we have the knee flexed because that is the position of comfort. And when we find an area that is tender, we'll use that pain scale again. Keep in mind, the psoas is an emotional fight or flight kind of area and muscle. So you may, and you would want to ask for permission. You may find that they don't want to work at that level of intensity, and so you would respect that. But in this position, you would then palpate. Should you feel a pulse, then you would want to locate either more medial, more superior,